Yes,
Evans, can we?
only agenda Evans is to start.
Yes. Please, can you hear me?
Yes.
Okay.
Can
Thank
we
you very
begin?
much. Sorry, can I start?
Yes.
Okay, thank you. All right. So, good afternoon, everyone. And my name is Evans Akanwe Atim. I work with AFREhealth as a senior programs manager. Nice meeting everyone. On behalf of AFREhealth and our partners, it's our pleasure to warmly welcome you to today's Pandemic Preparedness Certificate webinar. Indeed, we are delighted to have you participants join us across Africa and from different parts of the world. Thank you for taking time to be with us today, regardless of your time zone. And we believe your presence this day reflects reflects our shared commitment to strengthening pandemic preparedness through collaborations, learning, and exchange of knowledge. Before we begin today's webinar, there are a few housekeeping rules we would like to put out just to ensure we have a smooth, productive session for everyone. Firstly, please note that this webinar is being recorded, and by staying on, your consent to this recorded session is implied. Would also advise that everyone should kindly, for clear audio quality, keep their microphones muted. Thirdly, on camera, we encourage participants to keep their cameras off during the session to help preserve bandwidth. However, our speakers and panelists will have their microphones and their speakers on when presenting. This is also, as you may have been informed ahead, this is an interactive session. And so during the Q&A sessions, we encourage that participants should actively contribute or submit their questions using the Q&A features or the chats. Our moderator would, as much as possible, address or pick up these questions to be addressed by our eminent panelists. In case you are struggling or having any technical issues, we advise that you reach out to any of our technical team on the call, and we'll be more than happy to help address that. Now, while we wait for others to join, I would also encourage that please let's introduce ourselves by dropping our names, our institutions, and countries in the chat box. It's always lovely to see how wide and how diverse our audience are joining from different parts. And ladies and gentlemen, these are our housekeeping announcements. Once again, thank you for your attention. And now it's my pleasure to hand over to the coordinator for this session. And over to you, Dr. Roy Muboki.
Thank you, Evans. Thank you very much, colleagues. And we are happy to have you on this webinar. So in order not to waste time, I'd like to invite the Executive Director of AFREhealth, Madam Georgina, to give us some welcoming remarks for a few minutes before we proceed to the session. Madam Georgina.
Thank you, Roy. Good morning, good afternoon, good evening to everyone from wherever you hear the sound of my voice. I believe that you are all doing well, and we are very grateful to you for making time to be in this webinar. I wish to welcome all of you to the first session, which is the English session of the Pandemic Preparedness webinar series that AFREhealth is working on to prepare all of us, whether we are students, we are frontline health workers, we are researchers or other workers whose work impact on health, for us to effectively manage pandemics. I would like to assure our francophone and lusophone speaking colleagues that we have your sessions also coming on in August. And so get prepared for that, because this program is not only for the English-speaking people. Also, just to give you a few things about AFREhealth and how we've contributed when it comes to pandemics and epidemics. AFREhealth as an institution which spans across the continent, with some members also across the globe, looks at how we can transform health professions, education, research and service delivery. And we look at that especially with our brand, which is interprofessional education and collaborative practice. We believe very well that professionals working in silos will not bring us the quality health care and the health outcomes, the better health outcomes that we are looking for our people on the continent. And therefore, we need to bring ourselves together, understand what each other does, appreciate it, and then we work together so that we can all improve the lot of our people, which includes we ourselves, including myself as I speak here. And so AFREhealth has been doing very well in that area. And so you can find on our panel, we have people from various fields who are also on to support in this webinar for us to be able to educate people and equip you to better handle pandemics. And some of the work that we've been doing, just to talk about the recent one, with Ebola, AFREhealth has taken it upon itself to be running series of webinars to educate people on the pandemic, on the epidemic, and we've run 2 sessions already, and we have others also reviewing. When we had COVID, AFREhealth also ran series of webinars to educate and also to equip health professionals and other people on how they could effectively manage the situation. And so AFREhealth is very much concerned about that, and we know that as the world continues to move, we are certainly going to face pandemics and epidemics, and it's very important that we equip people to really prepare themselves for that. So on this note, I wish to say that please fully participate. If you have questions, you put them in the chat, and then you learn more, and whatever you learn here, you also work. I wish you an enjoying time in this webinar. Thank you, and over to you, Roy.
Okay. Thank you, Madam Georgina, Executive Director of AFREhealth. And like indeed you've said, Africa has had its fair share of pandemics and epidemics, Ebola, COVID, and others, and certainly more are yet to come in future. So we have to be prepared for such situations. So hence the necessity for this webinar. So with us today, we have a panel of experts who are going to take us through this webinar. And I'll just briefly introduce you the experts that we have who have been at the frontline task forces, addressing the scourge of epidemics and pandemics in Africa. So the first panelist that we have today is Dr. Ambrose Talisuna. You will see him when he comes to talk. Dr. Ambrose is the Chief Executive Officer of the Africa Public Health Foundation in Kenya. I won't go through all their CVs because they are long, but he's an epidemiologist as well and has been at the forefront of fighting epidemics and pandemics on the continent. The second panelist will be Professor Pauline Viachika Kibuika. He's a physician, an epidemiologist, a researcher, and the current Vice Chancellor of Mbarara University of Science and Technology. She has also been at the forefront of the scientific task force addressing pandemics and epidemics in Uganda and on the continent. Then we have Ms. Melissa Pashuk, who is a digital communication specialist from University of California, San Francisco, also working in the Center for Pandemic Preparedness and Response at UCSF. She has also been part of the pandemic preparedness and response. These are the panelists that will take us through this webinar, and they are going to be, this panel is going to be moderated by our very own distinguished AFREhealth president, whom I'm going to hand over to take over, inviting the speakers and moderating the panel, Professor Nelson Sewankambo, who is a professor emeritus at the School of Medicine, Makerere University, the current president of AFREhealth, a researcher, educator, and has also been at the forefront of, researching, but also proposing solutions on how to handle pandemics and epidemics globally. So, Professor Sewankambo, I'm delighted to invite you to take over, invite guest speakers, and moderating the panel. Thank you very much.
Thank you very much, Roy. Since we are behind time, let's move quickly. Can you hear me?
Yes, we can.
It is fine. Okay.
Yes.
So let's get Dr. Talisuna to talk to us, and I'll not go through the topic that he's going to present. I'm sure you will hear it from himself. Dr. Ambrose, you are welcome. Floor is yours. Ambrose.
Thank you very much, Professor Sewankambo. Good morning, good afternoon, good evening, wherever you may be, as Mr. Lisuna, and I serve of the Africa Public Health Foundation based here in Nairobi, and in the policies, financing, leadership, governance. But really, I have coined this as a saying, we've had several agreements. We really need to move from agreements to action in building health security. So what is the context in Africa? So we all know infectious disease epidemics, pandemics, and other public health and humanitarian emergencies threaten the health of populations worldwide. But the big in countries implementing the international health relations, but as COVID has shown, there are major gaps and in health security and resilience. Years ago, we had in 2004, and then a year later, the pandemic. We really have to make a chance to make sure that we can put that promise to fruition. The WHO Pandemic Agreement, the amendments of the international test for us in Africa, and the test is simple. Can we turn global agreements into regional, national, and local protection? The next pandemic will not wait for a meeting, a conference, or webinar. It will start in a border town, a displaced population, a refugee camp, a setting with fragile conflict and violent setting, or a clinic without laboratory tests. So our job today is craft solution options to see how we can protect Africa. And in the next couple of slides, I'll be giving some priority areas. But let me just say that we at APHF are working in support of the Africa CDC and other relevant partners, and we are redoubling our efforts to mobilize and advocate for resources and investments to drive a holistic approach to promoting health security and health system strengthening in Africa. Now, what are the strategic pillars for that? We do believe that we need to integrate strategies for health security and health system strengthening. We should be doing a holistic gap analysis of the international health regulation core capacities, but also of the systems. And then once we have assessed that, we should be developing holistic plans, health sector strategic and development plans. And then we implement what we are really calling epidemic-ready primary healthcare at every primary health facility, which means an essential package of services, but also including catalyzing some of the orphan areas that we have seen, like improving access to mental health treatment and services. The other second priority for me is foster strategic partnership. Now, expand the partnerships for implementation, Africa CDC, WHO, regional economic communities, but also diversify investment partnerships. The people who give us money strategy so that we have a group of countries moving together in unison. East African community, West African community, SADC. The third strategic objective for me is to implement One Health and collaborative surveillance. You all know that most of the outbreaks we are seeing are originating on the human, animal, and environmental interface. So we really need One Health surveillance. But also, do we do that? Look at what is happening now in Ituri. We had things happening in the animal sector. We didn't see that spillover. By the time we got the spillover in the human sector, the outbreak was out of control. If we had animal health surveillance in hot spots like in those areas, I think would have nipped that outbreak in the bud. The fourth priority for me and the subject for this webinar is having resilient and equitable health and care workforce in terms of training them. So universities pulling them out, quality of the training, but do we retain them? Retention of health workers, but also to have a regional pool of such capacity that we can deploy in case we have outbreaks. The fifth point is laboratory networks. And I really regional laboratory networks because they're important to track high-threat pathogens for genomic surveillance, but also for antimicrobial resistance. And we at PPHF really want to drive this, where we have regional networks that can help us to do genomic surveillance and be able to track high-threat pathogens. And African-led public health research, R&D, and promoting manufacturing. But this will require a rethink because we have seen a market failure in the Bundibujo virus. We don't have diagnostics, we don't have vaccines, we don't have therapeutics. But we need to enhance R&D and local manufacturing in Africa to shift from crisis response to an engine of long-term health and economic sovereignty. And I'll be coming to this in the discussion later. We need continental transformation to shift this agenda. 7, financing. We really need financing, move away from donor dependence. We need domestic financing, and this domestic financing might not necessarily be budget support. It could be actually private sector financing from levies. But what we really are thinking quite a lot at NIRI, might be our next, is the whole issue around a solidarity fund for health security in Africa, where people put a pool. Could be the private sector, could be philanthropy, could be member states themselves. So that when we get a crisis, we don't only respond, but we build systems after we have had the response. So we just don't jet in and jet out and then take off. And then for me, finally, it's really leadership, governance, and institutional shifts. We need continental coordination with the bodies that are responsible, African Union, WHO, Africa CDC, the regional economic communities, but also the African Medicines Agency for its regulatory and standards for pooled procurement. And for us, of course, at Africa Public Health Foundation, really we're trying to deal with resource mobilization, communication, and making sure that some of the grants that we manage are reaching the countries and also the partners that we work with. But we also need accountability frameworks and data sovereignty. So I have a call to action as I end, Professor Sewankam. The pandemic agreement and the amended IHR give us the rules. The African Union, the Africa CDC, and the WHO provide us the political and technical leadership. Member states and donor partners provide us the resources. PPHF, for example, here, we are the go-to partner to manage multiple donor resources, including portfolio fund management for multiple funds, especially if we get the Solidarity Fund. But I want to say, rules, plus political and technical leadership and resources only matter if we act now and we act together. So let's commit to every region having robust real-time surveillance, every country having epidemic-ready PHC, and every region having an adequate health and care workforce and a laboratory network. The next epidemic should get us ready, Africa leading. I thank you for your attention. I end with that proverb, and I will not go through it, but I just want you to read it. Thank you very much for listening to me. Over to you, Professor Sawankambo.
Thank you very much, Ambrose, for getting us started. Colleagues, keep your questions and comments in the chat if you have them, and we will get back to Ambrose after the other presenters have also presented. So the second presenter was also introduced earlier, no other than the Vice Chancellor of Mbarara University, Professor Pauline Biakika. Pauline, the floor is yours.
Thank you, Professor Sawankambo. I hope you can see my slide.
Yes, we can see the slides.
Okay. Okay, I was having difficulty turning on my video. I hope you can see me now and hear me
Yes.
well.
We
The
can
topic
see
I was
you.
given, thank you. And thank you, Ambrose, for setting the stage. I was asked to speak about educating the African health workforce for future pandemics, focusing on training, community engagement, and institutional collaboration. Oh, my slide won't move. Sorry, my slide is not moving. Let me try and get it. Stop sharing. Share again. Maybe I'll not put it in presentation mode so that the slides can move. Oh, doesn't turn still. What should I do? Roy, what should I do to get these slides to move? To change?
Even when they're not in presentation mode.
Well, try using your
Sorry?
your keys, the left hand key or up or down. It's mostly work for laptops. The arrow keys.
The arrow?
Yes.
The up and
Still
down
doesn't.
arrow.
Still doesn't move. Roy, should I send it to you? And
Please
Try
use your
tapping on the
use your
screen too.
I use what?
yes, you tap the screen first. Use your mouse to tap on the screen first, and then you use the arrow key.
Then you use arrow.
Okay. Okay, good. All right, good. Thank you. So yeah, focusing on training, community engagement, and institutional collaboration. I'll start by saying that pandemics are not only biological crises, they are workforce crises. As we saw during the COVID-19 pandemic, that exposed weaknesses in every health system, even those that we thought were state-of-the-art health systems were challenged, and we saw weaknesses in their systems. The second point I want to put across is that vaccines and diagnostics alone cannot stop the pandemics. And the most important investment is the workforce. So Africa needs a workforce that is competent, a health workforce that is competent, that can be trusted by communities, especially during pandemics and also during outbreaks, that is continuously learning and is on top of their game continuously, that is digitally connected. We know we are in the era of digital technology, and therefore the health workforce must be digitally connected, must be working collaboratively and interprofessionally. The question is no longer whether another pandemic will occur, but whether our workforce will be ready for the next pandemic. So I just want to speak a little bit about lessons from the COVID-19 pandemic. We learned that preparedness cannot begin during an outbreak. The training must have occurred beforehand, and the preparedness should have been established beforehand, before the outbreak. The health workers require broader competencies. It's not enough to be a clinician. You need to be a kind of all-rounder to acquire broader competencies than just the clinical competence. Not only that, clinical management, but including competencies in surveillance, in communication, leadership, digital health, and research ethics. But leadership is key, as we saw during COVID-19. We also learned that communities determine success. Without community trust, vaccination will fail, isolation will fail, and surveillance will fail. The fourth lesson is that institutional collaboration matters, and no institution will manage pandemics on their own. We need to collaborate. Continuous learning saves lives is a fifth lesson. We know that knowledge evolves rapidly, and health workers should acquire lifelong learning skills. So what competences should we build as we prepare for the next pandemic? We need the health professionals' curriculum to integrate key aspects that are required for pandemic management, and these include skills in interpreting evidence. As we saw during COVID-19 pandemic, everybody seemed to interpret the evidence in the way they liked, and sometimes not very accurately, but they interpreted, and sometimes they went ahead to implement the way they interpreted the evidence. So skills in interpreting evidence are quite crucial. Outbreak investigation is important. Infection prevention and control skills are very, very important. As we saw during COVID-19 pandemic, some health workers did not know about IPC measures. Some had never seen some of the PPE required, and they were seeing it and having to use it for the first time. So it is important that as we train the workforce, we go through these important skills. Genomic and laboratory surveillance, risk communication, emergency ethics, including both medical ethics and research ethics, implementation and translation science, digital health, as well as One Health principles. Graduates should leave the university equipped with most of these competences rather than acquiring them during a crisis. I want to speak a little bit about interprofessional education. Our education systems for the health workforce need to train for teamwork and not training professions to work in isolation, because pandemics expose the limitations of siloed education. We know that physicians, nurses, pharmacists, lab techs, public health professionals, and so on must learn to work with, learn from, and learn about each other through interprofessional education. And this is one of AFREhealth's greatest strengths and should remain central to the future workforce development. Community engagement is very, very important because the communities are the first responders. We have heard and read what is happening in the DRC, where communities were either not engaged, or were not appropriately engaged or adequately engaged, or they selected to follow their own theories and behavior, and they ended up banning an Ebola treatment unit. So community engagement, for the community to understand the various means of control of pandemics, and for us to get their trust and participation is very, very crucial. And without community trust, there is no pandemic preparedness. And we shouldn't wait to engage communities when the pandemic begins. It should be performed much, much earlier as we get prepared for the next epidemic. Here, I wanted to say that universities are preparedness hubs, and these 8 aspects should become part and parcel of university training, where we should have universities as education centers, as research centers, innovation hubs, simulation centers, and the graduates coming out as policy advisors. We should have data centers, community partners, and rapid response teams that are able to be deployed during pandemics. So rather than responding only during emergencies, universities should prepare continuously and should be able to respond at any time. Institutional collaboration is key, as Ambrose has talked about, and it's important that we build these networks and collaborations much earlier, as we know that none of these institutions can fight a pandemic on their own. If we have the public health institutes not working with the hospitals, definitely it will still not work. So institutional collaboration is part and parcel of preparedness. The digital transformation is here and we have to follow. If we don't follow, we shall be left behind. Even for pandemic preparedness, this is quite critical. We need to ensure digital learning. We need to ensure that we adopt telemedicine skills, artificial intelligence assisted surveillance with early signal detection and timely response, electronic reporting with real-time data flow, with interoperable data platforms, with online simulations, virtual mentoring, and regional platforms that are also interoperable and communicating to each other. So building the future workforce, I have here 5 interlocking priorities for the health professional education to build for preparedness across the continent. And these require modernized curricula. I know that we are all currently in the East African community and most of Africa are going through educational reforms that include transforming all our curricula to competence-based education and training. So we need to move to that and align this with real-world practice and get out into real-world practice as much as possible. We need to develop faculty, train the trainers so that they keep up to date. We need simulation-based learning, community partnerships, and regional collaboration that Ambrose already talked about very well. So here I talk about stakeholders, and I think I don't need to dwell on this. I will skip that slide. Finally, as I finish, I just wanted to say that Africa has demonstrated extraordinary resilience during the recent pandemic. And the next step is to institutionalize the resilience through our education systems. And through interprofessional education and practice, we can prepare health professionals who are scientifically competent, digitally connected, community engaged, and able to work across disciplines and across borders. We can transform pandemic preparedness from emergency response into permanent capabilities. Thank you very much for listening to me. And finally, I'd like to announce and welcome you to the 9th AFREhealth Conference, scheduled to take place from the 24th to the 26th of August at Speak Resort Munyonyo, hosted by Mbarara University of Science and Technology. Thank you for listening to me.
Okay. Thank you very
Back to
much.
you, Chair.
Thank you very much to you, Pauline, for that clear presentation. Please, let's go to the third speaker, and I encourage the people in the audience to put their questions or comments in the chat. So the next speaker, Melissa, Melissa, what is the second name? Melissa Paschak. Sorry if I'm mispronouncing.
It's okay.
She is going to talk to us about the work she's been doing with the STRIPE. She's from California, UCSF, that is University of California, San Francisco. Please, just the floor is yours, because we are
Thank
running
you.
late.
Yes,
Yeah.
thank you. I'm going to share my screen. Hello, everyone, and thank you for the opportunity to introduce the STRIPE HIV Pandemic Preparedness Certificate course, or PPC. The PPC is a training program designed to address two of the competencies that Dr. Biakaka just mentioned, surveillance and communication. The PPC is designed to help frontline healthcare workers strengthen the knowledge and skills needed to prepare and respond to infectious disease outbreaks. The course focuses on three key areas: identifying early warning signs of emerging or re-emerging infectious diseases, reporting potential outbreaks through appropriate public health channels, and communicating effectively with patients and the wider community during outbreaks. The course consists of 2 interactive modules. These modules can be completed in approximately 4 hours. It is designed for interprofessional healthcare teams, such as those described by Dr. Biakaka, and to take together. Let's take a closer look at what participants are going to learn in each module. The first module is Introduction to Outbreak Disease Surveillance. This module introduces participants to the role of epidemiology and public health practice and the importance of outbreak disease surveillance. Participants learn how to recognize early warning indicators of a potential outbreak and how to report a potential outbreak within their own context. The second module is Communication during Pandemics and Outbreaks. This module focuses on communication during public health emergencies. Participants learn about the objectives of outbreak communication and demonstrate effective verbal and written communication skills for working with patients. Together, the 2 modules provide complementary skills that support outbreak preparedness through both surveillance and communication. Now, I'd like to show you the different ways you can use the modules. So the PPC course can be completed in 2 ways. First, organizations can choose to offer the full facilitated PPC course. This allows participants to earn the Pandemic Preparedness Certificate. Facilitators will have access to materials on the PPC course website to organize and deliver workshops, and participants will earn their certificates after completing both modules, the required assessments, and the course survey. The modules can also be used independently as educational resources. They are available on the STRIPE HIV course website for organizations or individual learners who would like to use the content without participating in a facilitated certificate program. This flexibility allows institutions to choose the approach that best fits their educational needs while making these learning resources broadly accessible. It's important to know that the modules were designed around the facilitated workshop with interprofessional learners. The modules were designed to be interactive, with facilitators guiding discussions, activities, and debriefs among interprofessional teams. The independent learning option provides access to the same content and materials, allowing individuals to work through the modules on their own. While these learners won't have the benefit of facilitated discussion or group interaction, they can still engage with the activities and reflect on how the concepts apply to their own practice. If you choose the facilitated workshop option, this is what the learning experience looks like. Each module begins by introducing key concepts, tools, or frameworks. Participants then apply those concepts by working through realistic healthcare scenarios that reflect challenges they may encounter in practice. Working in interprofessional teams, participants also discuss cases, solve problems, and learn from one another. Facilitators guide the discussion and lead a debrief to reinforce key learning points and connect the activities back to the module objectives. To support the facilitator, each module includes a facilitator guide with step-by-step instructions, discussion prompts, activities, and key teaching points to help facilitators deliver an engaging and interactive workshop. If you'd like to learn more about the PPC, see the course website, or discuss offering the course at your institution, please contact Roger Lawrence at AFREhealth using his email address, rlawrence@afrehealth.org. Thank you very much for your time today. I'd be happy to answer any questions when the time comes.
Thank you very much, Melissa. So let's get into some discussion time. In fact, at this point, I hope the speakers, the three speakers, can engage each other around what they have presented, even what they haven't presented, and one is interested to know something outside. So let me request Ambrose to get the discussion started, because you specifically promised that you'll get back into the workforce issue during the discussion. So please, here's the opportunity for you to do that and see how your ideas link with what Pauline Biakika has stated. Ambrose, would you like to get started?
Yeah, thanks, Professor Sewankabo. I know Pauline has raised a couple of issues, but what I specifically wanted really to follow on from a health worker perspective are the reforms that we really need for us moving forward for sustainable investment in pandemic preparedness education. And Melissa has raised some of those issues in that training. But specifically, I think one we need financing and budget policy reforms. One of the issues that you see at the moment is that really medical and health education is really underfunded. So I would think that for us really to be able to sustain that funding, we really need some kind of earmarked funding, that budget lines that are protected in annual budgets for preparedness and health security training. The second is we really can't sustain our workforce if we are really going to depend on external financing. So I do believe that better domestic financing, and again, when people talk about domestic financing, people think it is only budget support, but we could actually get domestic financing from private sector levies and targeted tax credits that then go to training. And then for me, the second issue is our Ministry of Education and Ministry of Health reforms. If you look at the current, and I will take a few cases here, when people are planning for education and training, the Ministries of Education is doing it in silos, and the Ministry of Health is doing it in silos. The training institutions used to be part of the Ministry of Education, of Health. They have shifted. So really, these issues, we really need to have joint health education and health training plans, where we standardize core curricula that embark on outbreak science, and make sure that outbreak science is in the training mode, in the training curriculum. The issues you're talking about, infection prevention and control and WASH and biosecurity, should be embedded in the training curriculum. Interdisciplinary training, I think Professor Pauline talked about this. I really think that universities should look at programs which are looking at training as teams, like Professor Pauline was saying, epidemiology, public health policy, data science, communication. But also, I really believe that we need curriculum reform. And we should be getting graduates who are epidemic response ready. So I really think that that should be something, one of the issues that we should be addressing. And then finally, for me, I think looking at international standards, how do we align national training programs with global standards set by the WHO, global standards set by the African Union? And the whole issue around mutual recognition of training in different parts of the country. Sometimes I've been in outbreak response, and we look at such capacity, and you have people going to a place where they need such teams, but they are not accredited. They're not allowed to work there. A nurse can't, an IPC nurse will not register. So why should a nurse who has trained in Uganda in infection prevention and control require accreditation when she crosses to respond to an outbreak in Kenya? There must be some mutual recognition. And so for me, I really think that these are issues that both countries, but also the bodies we're setting up these mandates will ensure that there is standardization. And finally, I think we need accountability and infrastructure reforms where we have independent oversight of how training of pandemic preparedness is done. Digital infrastructure, of course, is going to be critical. Some of it might require catalytic funding with grants to countries. But the shift really for me is our governments should invest in health workforce training so that we have pandemic-ready graduates coming out there. And one of the issues that I've been struggling to say is that can we include some certification so that from community health workers, if people are certified as they have been trained in pandemic preparedness up to the doctors, they shouldn't be licensed. So that you only get people who are ready, they have some kind of the modules that Melissa is saying, but a comprehensive module that is not only looking at surveillance and communication, it's looking at the entire outbreak investigation and response. And if somebody hasn't done that, a basic one for community health workers, nurses, doctors, why should they be licensed to go out there and work in a primary healthcare facility when they are the ones who are going to be seeing the first outbreak there and they will miss it? Over to you, moderator, please.
Thank you very much. You've raised a couple of issues there which we need to delve deeper into. But let me go to our Vice Chancellor. Curriculum change. Ambrose has also emphasized that. In your experience, what is it that institutions are not doing right to have the curriculum revision and include what has been talked about? My experience when I was did before and other levels is people want so many things to be in the curricula of a health profession, and getting the curriculum revised was always a nightmare. What are your thoughts on this curriculum change?
Thank you, Professor
And this
Sewang.
is generally on different health professions, not only the doctors.
Okay. Thank you very much, Professor Sewankambu. Before I speak about curriculum change, I think we need a major mindset change for both the teachers and the students in training, the health professionals who are already qualified and those in training. The various cadres need a mindset change. Sometimes I wonder, maybe away from COVID pandemic, but just looking at Ebola, with people in the health facilities will not think, they will not have this index of suspicion. And a patient will go through a facility with signs and symptoms and will be treated right from the time they entered the facility, the gate man, the sweeper, the triage nurse, the dispenser, the medical doctor. The patient will go through all those pathways and none of them will have taken IPC measures while interacting with that patient. And it will be until several weeks later, maybe 7 days later, the Ministry of Health will come back to investigate who was in contact with this patient, who had particular symptoms that were suspicious of a highly infectious disease. So mindset change. Why am I saying mindset change? People do not practice what they learn. They still stick to their kind of bent practices and will not establish or institute the IPC measures in the facilities. That's one aspect. And I really attribute that to a lack of the mindset. I attribute it to the mindset. Then secondly, when I come to curriculum reforms, of course, we know health professions training has mostly been competence-based. It's really practical. But some aspects, especially those to do with epidemic response and epidemic investigation and surveillance, are not practical skills. They're learned in theory. If you go through the nurse's curriculum or the lab scientist's curriculum or the medical doctor's curriculum, they'll speak about these aspects, but they're all in theory. They will not go out into the field to practice them and actually experience what they should be like in the field. So we are still theoretical on many aspects, especially those that touch on pandemic and outbreak investigation. I think also curriculum reforms, when we look at our basic science training, and Ambrose touched this, he said we need to think more about our research and development, research and innovation. In this country, we don't have a lot of basic scientists qualified in the early, the manufacturer, the biomedical kind of sciences. It's still a field that we haven't, I won't say we haven't taken seriously, but it hasn't yet been very well developed. And when you look into manufacturing of biomedical supplies, vaccines, medicines, diagnostics, we're still lacking. So people will learn about this in class in theory, but they will not have that hands-on exposure in the laboratories or in the manufacturing plants, so that they get stimulated to think more about manufacturing and actually go into the manufacturing practice. The innovations are also still at a very low scale, and oftentimes they're not facilitated. They will drop off after maybe a prototype stage because they cannot proceed to the next level. So still that calls for curriculum reforms. But it also calls for the country to invest more into manufacturing, biomedical manufacturing, diagnostics, therapeutics, vaccines manufacturing. I'm glad that for Uganda, at least we are seeing some of this coming up, but it's still not at the scale that we'd like to see it. So there's still a lot of room for improvement for our countries. I'll stop there for now, Professor Sewankam.
Thank you very much once again. What you've said actually takes me very well to Melissa. Melissa, the course that is being implemented by AFREhealth, tell us how it links with the practicalities, what they learn in the course, and how the practical aspects come in. Because Pauline has emphasized the lack of practical experience, not from that course. She's speaking in general and about others. What would you say? Or what do
Sure,
we
thank you.
need to be done? What do we need to be done differently on this course?
Sure, thank you very much. So this curriculum was really designed to help begin to fill a gap in training, and as a quick way to get training done in a way that's easy to implement. This training, I can't stress enough how important it is for interprofessional groups of healthcare workers, doctors, nurses, midwives, labs, even administrative staff in public health to work together through the training. And this is why we require it to be a facilitated workshop in order for you to earn the certificate. It is during that training with those people working together, looking at real world issues and discussing them and seeing the different perspectives on how things would be solved. And then taking what they discuss and directly applying it to their everyday practice. We really try to help learners in this course transfer what they're learning in the module, in the workshop, to the real world. And that's part of the facilitated discussions and reflections. And it's really a course that is for everyone involved. I will stop there and turn it back to you, Dr. Sowen Combo.
Yes, thanks again. One of the issues that may arise in these countries, failing to prepare a health workforce well, is funding, and Ambrose labored that point very much. Let's go back to that point. And this cuts across even into Pauline's presentation. I mean, you hear different countries on the continent saying that financial resources are in short supply. What in practice, let's talk practice. Yes, we know we should raise domestic resources. What is it in practice that will give us resources to prepare our health workforce better? Because for them to have practical experience, there is resources. But before we even discuss the resources, I wish to say a change in mindset, as was emphasized by Professor Biakika, is extremely important, both for the trainee and the trainers. Now, I think also for raising domestic financing, mindset change within government and outside government is important. So Ambrose, give us some more discussion on this issue of raising domestic resources. Again, what are we not doing right, or where we are not putting enough effort? And Pauline will come in to tell us how raising these resources to do the right things with the curriculum and its implementation in the right way can come into play. Over to you, Ambrose.
Thanks, Professor Sawankambo. And this one is really something that I like your framing this as a mindset change within our policymakers, because I think when people have been discussing domestic financing, the only thing that people talk about domestic financing is budget support. And if you look at, if you are a private sector, a commercial bank, which is doing a corporate social responsibility within Uganda, for example, if I use Uganda, within Kenya, where I'm based now, and they're funding health workforce training based, and is local, I mean, that is in itself is also domestic financing. So we should be looking at different types of financing. I mean, of course, there are issues around earmarking the budget support to the Ministry of Health, and say, can we say at least 5% will go to, at least 5% of the Ministry of Health budget will go to health workforce training. That is okay. That's a policy reform that we want. But the people who sit within this policy making decision, like to say we need to diversify our funding base, to look at the private sector which can support some of these things, look at philanthropy which can support some of these trainings in the country, but also for donor alignment. For example, you look at all these countries, they're doing their proposals to the workforce, to the pandemic fund of the World Bank. And I think that is dedicated, that is dedicated training, because there is a component of workforce. But if you look at some of the health security proposals, there is a flexibility in what goes to workforce development. And I really think that we should have this narrative among the donors also, to say there should be a policy where you say you cannot implement any health security and health system strengthening grant unless you have training. A certain percentage of your budget is going to workforce, because the workforce is the driver. They're the ones who deliver these interventions. So for me, that is one. The second, of course, is really efficiency gains. I really think that we can do better with so little. There are several things that can be done with the resources that we can do, and having joint trainings where you have the team trainings, so that you don't have parallel trainings for IPC nurses and you have another parallel training for laboratory people. And I think to have those joint trainings for different components of health security, we can have efficiency gains. So that's interdisciplinary training, whether it is in service or pre-service. And I think finally for me is to say, at the global level, if we are really going to build, some of it requires a regional workforce. I do believe we need a solidarity fund. A solidarity fund where a solidarity fund means that really we are helping each other to be able. So if DRC has a problem and we have a solidarity fund managed somewhere, we run in and help. After the outbreak, we look at which were the orphan cadres and build those cadres. But the same will happen to Uganda the next time. The same will happen to Kenya. The same might happen to South Sudan or Nigeria. So first, every country, all the 54, 55 member states should be able to say, we put in something to this solidarity fund for workforce development. And then we can look at other funders who can help in terms of whether the multilateral banks or bilateral banks, part of their social corporate responsibility, who can put in that solidarity fund. And then we can say, this solidarity fund is going to drive regional health workforce development so that we are prepared for the next pandemic. So there are avenues, and I think there is still ongoing discussions on this. Some of them are in country, some of them may require regional bodies to drive them, because if you're trying to look at regional workforce development, then we should be coordinated and to make sure that we are standardizing quality. So I'll stop there, but I really think the discussion needs to begin. We broaden and think beyond budget support. And finally, of course, how do we deliver the services themselves, the things that have been, which you might have health workers, but you need to deliver services. So the whole issue about having insurance schemes, social insurance schemes for the delivery of services. But with respect to workforce development, I think we should diversify our funding base beyond budget support. Over to you.
Thank you. Colleagues, I'm keeping my eyes open into the chat to see whether there are questions, and I haven't seen any questions. But if I'm missing it, please let me know. Pauline, do you want to chime in on this issue of funding, raising funding to support what we want to do as educators and so forth, researchers on the economy?
Yes, thank you. Yes, thank you once again, Professor Sewankambo. I think that raising domestic funding can fundamentally change the way we do things, the way we think, the mindset, and the practice. It also raises hope amongst the population. And I think hope is one of the greatest, what should I say? Is it an attribute or giving hope to the population is key for the health workforce to know that there is adequate domestic funding, even if it's not adequate, but increased domestic funding, and that health is taken as a priority. Then they stop to think in crisis mode and will have it as a continuous planning and acting cycle. So they will have preparedness as a continuous aspect of what they do. But otherwise, if the funding is too low, people will not even think of IPC because the resources are too minimal to, it's looked at as a waste of resources, to incorporate in daily practice. So, but if the domestic funding is increased, then that becomes part and parcel of daily practice. The resources will be available and people will train in an environment where they are seeing things being done in real time, and they will not train in an environment of always improvising. I know one time one of the medical students told me that we teach them medicine of improvisation, that we're always telling them to improvise because of scarce resources. So really domestic funding can fundamentally change mindset. It can change practice. It will improve confidence and accountability, as well as continuous preparedness. But also, it brings about ownership. People feeling like they are part and parcel of the system, and they own the system, and therefore they have to work towards improving the system. Otherwise, if it is too little, it gives people, puts people in a system of, what should I say? They are they have given up on the system and they will not care anymore. So I, for one, really would push for increment in domestic funding for those reasons, for commitment, for accountability, for confidence, for hope, and for resilience. But also domestic funding for research is crucial because at the moment, if we do not improve our R&D for biomedical interventions, we're going to continue being dependent on the Western world. And yet, many times, these affect mostly the low and middle income countries. So we have to increase our own domestic funding and stop being donor dependent. And this domestic funding should span the R&D so that people can innovate more and we can go into local manufacturing of diagnostics, of therapeutics, and of vaccines to solve the problems that we face here locally. I think I'll stop here for now and listening. Thank you.
I would like to go back to Melissa, but before I do, there is a question here, a comment that Pauline, you should speak to. This is from Aaron Brown. I don't know from which country. He says, I want to get a better understanding on mindset change in policymakers. So, Pauline, you may want to comment on that, and Ambrose, because Ambrose, you are talking policy. Before we go back to medicine. Yes.
I think Ambrose should speak first about mindset change amongst policymakers because he's been a policymaker. I am more into education. But I think our policymakers really need a big mindset change, especially when it comes to prioritization and resource allocation. I think many times health is not taken as high priority as it should be taken. And also possibly because our policymakers do not experience what the common African in the local setting experiences, and that most likely makes them think differently. I don't know if it is because of that or if it's intentional, but I think that health is still not given the priority that it should be given by our policymakers when it comes to resource allocation. And I'll leave Ambrose to speak a little more about this since he's been in this field longer than I have been, the field of policy.
Ambrose.
I mean, I don't think I have all the answers. So some of the people who are in the audience might have some of these issues. But I mean, we have had, first of all, a failure. I mean, I don't know, for example, since the early 2000s, we've been talking about this 15% allocation to the health sector, which was 2001 from Abuja. And a couple of people have said, I don't know, how was this number actually reached? And that needs to be, first of all, revisited. I mean, Rwanda is probably moving towards 15%, Botswana is probably moving towards that. That those who have not yet moved, but does it really mean that if a country allocates 15% of this sector, if it's over national budget to the health sector, you'll change the narrative, and that for me is probably not true, because now if you look at also the discussion going on around health in all policies. So if you are talking about health in all policies, the Ministry of Agriculture is going to ask for health in its own policies for One Health. You're going to think that the Ministry of Education is going to ask for a health component because you have a school health component indeed. So the whole issue around 15%, you have military spending is probably is outdated narrative which should change. And we should now be looking at per capita expenditure on health. And where that per capita expenditure is made might be coming in through education, might be coming through the health sector, through agriculture. That is really what we should be having that mindset beginning from there. The second issue is in terms of shifting away from crisis training and we do a lot of crisis training when we have an outbreak. If you look at now for the outbreaks of the Bundibujo virus, both in Ituri and now Uganda is being declared free, if you look at what they are requesting for training, surveillance officers, but I think trainings that go on during crisis management, for me, they miss a point, because I think we should be doing some of this training. Yes, we can do refresher trainings during crisis, but we need to be doing trainings in peacetime. We need to be doing these trainings in peacetime. That is really what preparedness is all about. Now, in terms of resource mob itself, I think if we really start looking at mobilizing resources for training from the private sector within the country, even that constitutes domestic resource mobilization. Why shouldn't we mobilize resources from a commercial bank as part of their corporate social responsibilities to train people, field epidemiology training program that is run by University of Mbarara or University of Makerere, and those people come out and they deliver service. It's not funded by the government. but it's domestic financing. So all that is for me the people who are thinking about these policy positions should be looking at that. And the final one, of course, that I said is really, is frugality in what we do. I mean, we have a lot of wastage, and just better accountability in whatever trainings that we do with better fiduciary management is something that will probably save us resources, and that also requires a big mindset change. Over to you.
Thank you very much, both of you. Let me go back to Melissa. Melissa, joint training, which STRIPE is carrying out, with an interprofessional approach. Maybe two things. One is it has been mentioned that we should continuously do training and not wait for the epidemic or pandemic to occur, outbreaks to occur. Of course, STRIPE is a project in AFREhealth, but maybe you have thought about how AFREhealth can maintain that training year in, year out. Could you share your thoughts as an outsider, meaning you know, because you are from the US, how this could be done, but also what challenges, if any, you have observed, experienced during that training? Challenges that we on the continent need to look at and make sure that we will find solutions. And I think we are coming very close to the end of the session, but Melissa, you may have some thoughts to leave with us.
Sure, thank you. I think that what I will say will address both of those questions. That training can't wait, and the challenges to afford having trainings like these. So with STRIPE HIV, we've been a partner with AFREhealth for several years, and it's been a very strong partnership. We also have partnerships with other institutions across the African continent. These institutions, in addition to AFREhealth, are currently offering these trainings. And their universities, and most of them are universities, but they're working with local healthcare clinics and ministries to implement these trainings so that the training is getting done now, before, hopefully, the next pandemic, right? And one of the things that our partners are also working towards is getting accreditation for this training program through continuing education credits or through integrating it into the healthcare curriculum for their students who are going to be graduating soon. So if they don't have another more robust training already implemented, they have come out of their program with at least the Pandemic Preparedness Certificate program. And so I would encourage folks who are looking for something that is put together to give an introduction to pandemic preparedness through surveillance and communication to look at the PPC and consider endorsing it for continuing education credits or being implemented into your program for your new graduates. Thank you.
Thank you. Thank you very much. I will soon call upon Judy Caniola, the Vice President of AFREhealth, to come and give us a way forward. But before we do that, I've just located two questions. One is, by the way, the other question was from Liberia, the one of mindset. Bangomin Bodo is saying, that why has enthusiasm with which the policymakers supported research activity funding during the pandemic has dwindled? Is it due to differential risk perception? Or is it that the technocrats are not putting the case for investment through the policymakers clear enough? That is from the chart. And the other one, now I've lost the second one. Okay, let's deal with that. Anybody wants to comment on that? The second one was about training village or community caregivers. Okay, let's look at the one of does any panel member want to address this question? Comment a little bit on the question of why during the pandemic governments were trying to put money into research, but that has waned. After that, the second question was somebody requests a better understanding of how CUES, community health workers, and village health teams have been engaged to bridge this gap, more especially here in Uganda. And that was specifically for coding. And can we take 30 seconds for each question? If there's a response, if not, Judy comes in.
I will attempt to speak about the risk perception. And I think I hinted on it when I spoke about mindset change, although mostly I spoke about it from the health workforce perspective. From the policymaker perspective, I think risk perception is still an issue of mindset. Because if you saw what happened during the COVID-19 pandemic, policymakers were all up in arms trying to ensure that there were IPC, there were fundraising on the television. If you saw what happened in Uganda, and I'm sure it happened in all other African countries, they were all over the media fundraising, they were buying IPCs, they were stocking ICUs, they were talking about oxygen and so on and so forth. As soon as COVID was almost over, none of them continued to talk about these things. They went back to status quo. The expectation amongst health workers was that we're going to come out of COVID with state-of-the-art intensive care units with oxygen supply all over all African hospitals, with IPCs constantly present. But we went back to where we started, where we were pre-COVID. So it is still all a mindset change, and probably it is the environment that people have grown in. Sometimes I tell myself that I think some Africans have grown up in so much poverty that they cannot change their mindset. They continue to think with a poverty mentality, and that really affects us so much. And if we take poverty mentality to the higher offices where we are expected to make policy, then things will definitely not work. So I think it's all about mindset change. I will not say it's lack of exposure, because our policymakers really get so exposed, but they still come back to the same behavior when they come back here. I didn't want to speak so much about the priority given to defense, because I might step on toes. But if you look at the budget and the resource that is put into defense compared to that put into health, then you can really see that the risk perception coming from the health side of things is really minimal amongst our policymakers. And I think we need to continue speaking about it and advocating for a change. Over.
Thank you very much, panelists. Thank you very much for a very good discussion this afternoon. And I think AFREhealth will call upon you in the future.
Nelson, I wanted to say something. I want to say something about community health workers. I really think that's a valid point, the issue around community health workers and Jews. But I think it is really broad. I mean, if Africa is going to be pandemic ready, then we have to have trained health workers by level. So at the community level and the primary healthcare level, so we need people who have been trained. So however basic the module is, the community health workers, whether they are CHUs or they are extension health workers like they are called in Ethiopia, should be trained in outbreak prevention, preparedness and response. So, and those are the ones that I'm saying those community health workers should be certified community health workers who can then deliver interventions for outbreak response, preparedness and response. At the primary facility level, that also the nurses that are there should be trained and equipped. And then when you move to district hospitals at the district level, then we are then moving to a bigger team where you have rapid response teams that are always on the radio, incident management support teams. But the issue is that at each level, we should have a multidisciplinary team, or it might be someone multitasking for different disciplines, but at least they are trained. And the final point I really want to say, this notion that community health workers should be voluntary should stop. They should be paid. Over to you.
Thank you. Once again, thank you very much, panelists. On my side, let me remind the audience about what Pauline said, that the AFREhealth conference is coming in August 24th to 26th. And moreover, this country last reported an Ebola case on the 24th of June. That is, in the last 5 weeks, we haven't reported a new case. And therefore, spread the message to people even outside of this country to know that Uganda is Ebola free and they should come to attend the conference. Let me hand over to Vice President Judy Kanyura to say something in 2 minutes or 3 and close the webinar. Judy? Sorry, I didn't put on my camera for fear that my unstable internet would then be compromised. Judy, I hand over to you.
Prof, you've been very clear. I don't know, Judy is on, but she could be engaged. Perhaps Professor Tuambo, you can, as president of AFREhealth, I would like to officially invite you to close off this webinar.
Well, very simply, in a half a minute, thank you for all of you for attending the seminar. And I've already thanked, but I can say once again, thanks to the panelists who have given us a very good conversation, but also the people who organized the webinar. Thank you for all the effort, and I look forward to meeting you all at the annual conference. If we haven't had another webinar, that is a webinar run by AFREhealth before the annual conference. With that, on that note, thank you. And there was a participant who was wondering whether the presentations would be circulated to them. I leave it to the Secretariat, AFREhealth Secretariat, to do what they have always done and respond appropriately. We come to the end, and thank you very much.
Thank
Thanks.
you.
Bye-bye.
Bye.
Thank you. Bye-bye.
Bye-bye.
Thank you. Bye.